you for just bearing with us whilst we sorted out the webcast. So my name is Councillor Laura McLean and I'm the chair of this Health Scrutiny subcommittee. So before we get going, I'll hand over to Jay, who's going to read us the housekeeping arrangements.
Thank you, Chair. Please can I request that mobile telephones and other such equipment are switched to silent mode as to not disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to being filmed and to the possible use of those images and sound recordings for webcasting. Thank you, Chair.
Thank you. Could I ask that members please introduce themselves, and starting on my left here? Thank you.
Yeah, good morning. I'm Councillor Steve Rose. I'm Councillor for Graves Park Ward and I'm Deputy Chair of this committee.
Good morning. I'm Councillor Alan Woodcock, representing East Ecclesfield Ward, and I'm substitute member for Councillor Penny Baker.
I'm Councillor Toby Mallinson from Hillsborough Ward. I'm Green Party spokesperson.
Good morning, I'm Helen Steers and I'm here for Health Watch.
My name is Rory Gibson. I'm a resident doctor, member of MedAct Sheffield and asking a public question.
Councillor Fran Belbin, member for Firth Park Ward. Ruth Milsom, I'm a councillor in Crooks and Crosspool Ward.
Councillor Mary Lee Darnell Ward.
Thanks everybody. And in terms of apologies today, we've had apologies from councillors Penny Baker, Sophie Crossthorne and Willis Marshall. So I'll move on to item 2, which is items which are to be excluded from the public and the press, but there aren't any today. And then we'll move on to item 3, which is declarations of interest. So can I ask whether any members wish to declare an interest in any of the items of business on the agenda today? Okay, brilliant. And then we'll move on to item 4, the minutes of our previous meeting. So can I please ask members to approve as a correct record the minutes of the last meeting held on the 11th of September 2025? Is everyone in agreement? Brilliant. We'll move on to item 5, which is public questions and statements. So we've received one public question ahead of this meeting, and Rory is here to ask that question today. So welcome to the meeting, Rory. Would you like to ask your question?
Many thanks for having me. So, dear members of the subcommittee, my question is in relation to the rollout of the Federated Data Platform, also known as the FDP, across trusts and the ICB in South Yorkshire. The inclusion of the FDP within local data infrastructure plays a key role within South Yorkshire's ICB's data and insight strategy, and technologies associated with the FDP are already in use by certain trusts. The contract for the development and rollout of the FDP was awarded to Palantir Technologies via fairly untransparent means. Palantir has been criticised by the UN and Amnesty International for allegedly likely being complicit in human rights abuses, including the genocide in Gaza and oppressive surveillance in the US and Europe. Palantir's involvement in the FDP threatens patient data privacy and the deepening of health inequities, patient trust in health data systems, and the ongoing privatisation and asset stripping of the NHS. The BMA opposes the rollout of the FDP due to Palantir's involvement. Its adoption is not mandated by NHS England. How does the committee intend to evaluate the ethical considerations of inclusion of the FDP within local health data policy? And does the committee oppose the FDP rollout within South Yorkshire, considering the aforementioned information? Thank you.
Thank you. So firstly, I'd like to thank you for coming today to bring your question. So normally our process is that ahead of the meeting we would have provided a written response and then you could have come and asked a supplementary question. But unfortunately we weren't able to do so on this occasion. The ICB did provide us with some initial information, but there wasn't sufficient time for us to review that and provide you with a full considered response. And I'd like to go back to them to ask them for a bit more information as well. So we will provide you with a written response, and if you wish you can come back and ask us a supplementary question. You can do that in writing or you can come back in person. So we don't often have people come to ask us questions, so we would like to see more of that. So we do really welcome you coming here today, and thank you ever so much for your time. you.
Sorry to interrupt. I might have slightly skipped, but I think the is it Rory was asking members of the committee for our thoughts, and rather than asking the ICB, what's the process for handling that, for that kind of question? Because if the ICB are planning to produce a response, I think does that go to a different platform rather than?
No, so we will ask some questions of the ICB, and then we can provide Rory with a response. It wasn't something I knew. Sorry.
Response
from the committee. So that I will ask information of the ICB to get some information about this particular issue, and then I will write a letter on behalf of the committee and providing a written answer. Councillor Mallinson.
Thank you, Chair. I do think that this committee can take a position on issues, particularly issues of ethics, where ethical investment is, or ethical procurement is at stake. I think we can make if you like, a political statement about it, but I think it's a crucial issue. I think the sale of this data, the data system or allowing Palantir to run it, is a really worrying move, and I fully support the questioner's thrust. I think local health trusts really do need to consider very carefully whether they want to go down that route, and that we should be articulating to government as a committee and encouraging the health trust to do so as well, that this isn't a route that we want to take. Thank you.
Thank you. Councillor Aris.
Yeah, I'd like some clarification on that from legal, if possible, because my understanding is this is a scrutiny subcommittee of the parent committee, and whether it should be better be dealt with by the parent committee, who is more has the ability, and that's my understanding, has more the ability to take political submission.
Chair, quite happy to. Yeah, I've made a note of that. I want to go away and double check the Constitution, and I'll have a word with David Hollis as well around the roles and responsibilities. But I think it's fair to say that it's recognised that the question from Rory is of the committee, but in order to give the response, I think that the committee and the chair just need some more information from the ICB, as in asking them to just provide something, some background, to then be able to make a committee response. But I absolutely have written down, I want to do a constitution check as well. I'm not doubting anything that anyone's saying. I think for your own sakes, you just need to be clear, that's all.
Great, thank you everyone. Oh, sorry, Councillor Mallinson.
Just very quickly about going to David Hollis, I think obviously that's important. I think it needs to be clear that we aren't just a mouthpiece for the ICB passing on their sound judgment. We do need to scrutinise. We do need to take positions sometimes.
Okay. Yeah, thank you. So we'll move on to members' questions, which is the next item on the agenda. But we haven't received any this month, which takes us on to item 7, which is the Learning Disability Service update. So I'll just ask those speakers to come and join us. Thank you. Good morning. If you would like to introduce yourselves, please.
Good morning. My name's Helen Smart, and I'm the Chief Operating Officer at Sheffield Partnership University Trust, and I'm also the responsible manager for the Learning Disability Service and indeed the Learning Disability Project Board. And thank you very much. Nice to be here.
And I'm Heather Burns. I'm Assistant Director within the Mental Health, Learning Disability, Autism, Dementia Commissioning Team, as it currently is within Sheffield Place, within the Integrated Care Board.
Wonderful, thank you. So if you'd like to give us your presentation and then we can open up to questions, that would be great.
Thank you. Thanks very much. And as I say, thank you for being given the opportunity to update the committee on where we are with the Learning Disability Service. We're committed to plain language and easy read to ensure accessible information to all. So in the spirit of that, we've chosen to present slides rather than a lengthy report. Equally, I acknowledge that the public have access to these slides, and we wanted to ensure that everybody had access to this update. I am making the assumption that everybody has had the opportunity to look at the slide pack, but I will draw your attention to some of the salient points throughout the slide pack. So I'm just going to note the first slide tells us who we are, the second is around our vision and values, and the third is about our strategic framework. So I'm now on the working in partnership. And I guess what I want to pick out here is we at Sheffield Health and Care Partnership really want to get care in the right place at the right time. And I know that's sometimes a cliche, but it is absolutely what we aim to do, and have an effective urgent care service as well. But we are much bigger than alone. We're part of a much bigger system. And you will note all other partners that we work with and his input into our service, and which we are very grateful for. And this is not an exhaustive list. It just demonstrates some of the partners that we work with. The next slide is around the context and art. So I'm not going to go through all of the points here, but just to say that we know that people with learning disabilities do not live as long as people who don't have a learning disability, and many of these early deaths could be prevented. We also know that the total number of people with a learning disability in our population is not known with certainty, but we think there's about 1.5 million people with a learning disability in the UK. This could mean about 12,000 people with a learning disability live in Sheffield. And our aim is to ensure that everybody is, through the green paperwork, has access to mainstream services. So I'm going to hand over to Heather. So I've only been in Sheffield for 8 months, but my colleague here, Heather, has a lot of history in terms of the service.
So thank you, Helen. Colleagues, you'll remember that we've presented on a number of occasions previously when we were going through and asking for your support to develop this new model of care. And at that time, we'd had Fursal Rise, the inpatient service, which had been closed, but we were asking for your support to progress the new model of care, which was to avoid inappropriate admissions to hospitals, because hospitals are not homes, and traditionally people don't have great outcomes from that type of service. So we were presenting to you a new model of care, which was around focusing, bringing our community services together. They had been under the umbrella of learning disability services, but they had been 3 disparate teams. So that's the work that Helen and ourselves have been working on. So it was that kind of really properly integrated pathway with the professionals all working together in a much more seamless pathway for people. At the time, we were offering only standard weekday hours only, and we wanted to try to be a bit more flexible for that. And we had got some variable outcomes and longer waits. And one of the issues that we were finding is we got internal waits between the different professions as well. So Helen's been absolutely brilliant in her leadership around trying to make these teams fit for the future. So this is really an update on where we've got to against that model we talked to you about previously.
So if I take you through the model of care, and again, there's a number of bullet points there that you will be able to refer to. But we did note through the pilot and through work with MenCap and indeed with Sheffield Voice that actually the feedback we got was that actually the service, only a few people wanted a service before 9 o'clock in the morning. So maybe access to the service before they went to work, and indeed after they came back from work. We had only about 3 individuals that used the service over a 6 to 9 month period at the weekend, What we wanted to do, though, was to ensure up flexibility. So if people wanted to input to the service, that we had the flexibility to do that, whether it was 7 a.m. in the morning or 7 p.m. at night, and that was right through 7 days a week. So we've made sure that that happens. We are now a completely community-based service. If there is a bed required or not, then we would speak to commissioning colleagues and quickly identify a bed that is close to home and where individuals with learning disability can be cared for, still close to their home but in an inpatient setting. So you will see that we're doing a lot of work as well around autism as well. We're in the process of recruiting into posts that has real specialism in neurodivergence. We've also been working really closely with MenCop to improve the offer to people with a learning disability to reduce over-medication as well, and we are doing really well nationally there as well. I won't go through all of the rest, but just to say that you can see a review of the activity, productivity and outcomes and stuff, and is still currently underway. We've had some external support with that. We want to get this right. We want to make sure that any interventions that we have with clients are outcome-based and have a positive outcome and experience. We also are, as I alluded to earlier, through the green light and through working with partners, we want to make sure that mainstream services are accessible to everybody. So moving on to the next slide around our progress and our aim in delivering a fully integrated, person-centred community services for adults with learning disabilities. You will see the huge amount of activity and development here. Again, I'm not going to go through all of the text, it's no bullet points, the text here, other than to say again and emphasise the strong co-production with Sheffield Voice and the Learning Disability Partnership Board and the local authority, and as well as lots of learning disability clients that actually use our services and their families, of which we've had a great deal of feedback. We also provide, which is mandatory for all staff, the Oliver McGowan training, which is excellent training as well. We are promoting the health passports and the red bag scheme as well, and we are ensuring that anybody that actually comes through the service, learning disability service, has access to physical health services as well, and working very, very closely with primary care colleagues in terms of health checks. You will note that our flexible opening hours now are on a case-by-case extended hours approach. That way we can absolutely ensure that we're actually responding to any need that is identified. Moving on to the next slide is around our service improvement, and you will see the great work that's being done here. We have still work to do, as Heather alluded to, especially around waiting times between the clinical teams. We've managed to get that down from 113 days to 105 days. But actually I can sit here with confidence to say that we will be well below the 80 mark in the new financial year. We are working again, as I say, around efficiency and productivity, but actually in ensuring that we're delivering the best outcomes. You will note that we have 100% positive feedback from friends and family, and that is a really significant, and that's through a huge amount. It's not one or two families, we're speaking about a large number. We have, you will see the occupational therapy, physiotherapy, speech and language, and art and music therapy, and what's being delivered there, which is an excellent response. But what I would like to draw your attention to is 3 board committees. We actually had a grandmother who came to present her story to the public board around. She was actually a grandparent who's been caring for her granddaughter who has a severe learning disability. and she transitioned from the child and adolescent mental health service to the community adult learning disability service. The story described the excellent person-centred care experience from the learning disabilities team and how the multidisciplinary approach to meet complex care needs really worked for the family and benefited from care closer to home. She did indeed tell us that the care didn't just centre around her granddaughter, but indeed the whole family. And it was a concern she had around that transition from the children and adolescent service through to the adult service. And the board also heard how positive the support had been and in the involvement of carers. And for the first time in 20 years, she was able to have a family holiday thanks to the carer input into the family. The story provided assurance that holistic care of the community learning disability service reflected the importance of personalised care and the role of a family. And that patient story actually presented the theme throughout the whole board, and we referred back to it on numerous occasions. If I can take you on to the next slide, it's a case study about involvement and the inclusion that we've just heard. And you will see that just whom we work closely with and the areas in improvement as well, and how connections and working in partnership is really important. We are evaluating the service at every step as we go through the improvement programme. You well note that we've been working really closely with the Chief Executive at MENCOP, and as I say, local authority and indeed Sheffield Voice. But we have now a framework. We don't want our partnership working to be a tick box. We absolutely want it to be meaningful and to hear the voices of individuals with learning disabilities and indeed their families. This framework is something that is new, something that's in place. I don't think I'd be sitting here today with easy read slides had we not had that impact from our partners. We did indeed, we've just completed the Trust's annual report as well, which has been co-designed with our partners as well. So again, our annual report will be easy read and accessible for all. So the next steps in my final slide before questions is we continue to look at our data improvement plan and manual validation underway to strengthen accuracy and quality of our data. We have a new electronic patient record which is the RIO system, which we are migrating data onto now. Our estates, we are in a temporary residence, the Learning Disability Service, for the next 12 to 18 months, and we're looking for a long-term site that will, again, be accessible for anybody who should use it. Workforce, as I've said already, we're doing a productivity review and targeting recruitment to ensure we've got sustainable staffing levels aligned to service demand. We're widening that as well to make sure with our ICB colleagues that actually we are catering for autism and other neurodivergent areas as well. And again, we will continue to work and strengthen our collaboration and co-production with experts by experience, Sheffield Voices, our Learning Disability Partnership Board, and embed lived experience into our service design. Thank you. Is there anything you want to add?
Well, just the point about autism. So the original Transforming Care programme that we've talked about to this committee a number of times had a focus on both people with learning disability and autism, but predominantly people with learning disability. And what we're now starting to look at is how we can get into that similar work around people with autism to avoid avoidable admissions to hospital, because that's definitely an area of growth that we're identifying. So that will be one of our next things to look at.
Great, thank you so much. I'll open up to questions now. Okay, take Helen and then Councillor Aris and then Ruth.
Thank you, Heather and Helen, for that. I did have a question about the voices and people that you're talking to. I mean, you've explained your approach and you've given consideration to that. Going forward, are you giving any particular consideration to the voices that are missing, any particular communities that you're not actually connecting to, and will that inform how you manage your sort of forward plan with MenCap and others?
Yeah, I think it's a question that we need to ask permanently, isn't it? And when we did the original engagement work, we did try to reach out to a large number of people. I guess some of the communities that we don't get to are the concerns, isn't it? Those communities from particularly ethnic minority backgrounds. So I think that is just an ongoing commitment as part of the work that we're doing.
And I would hope that the framework we've developed captures that as we move along as well.
Yeah.
Thank you, Chair. Yes, I welcome this report, and I welcome the progress that's been made. We've had a lot of previous discussion before, so it's quite refreshing to see the progress that's been made. It's a general question, though, relates to the role of the ICB, and we've had discussions at previous subcommittee meetings about the impact of the reorganisation of the ICB and the cuts that have had to be made to the staffing. And there were concerns, Dr McMurray at the last meeting expressed concerns about that, the danger of that becoming a transactional exercise, and I think the minute says the nuance of the priorities may become. The question is, I've jumped to the question, what impact and what challenges do you anticipate that will have on progress going forward?
I can't sit here and say it won't have an impact, because 51% of the ICB staff will go, and that includes the Sheffield ICB staff. We're in a consultation process at the moment, so it's hard to see what comes out of that from the feedback that we're giving. I do personally have a concern about the focus on mental health, learning disability, autism and dementia in a new future structure, because I understand that there won't be specialist teams at place like we've had before, and we didn't have very many of us in the specialist team, but there were some of us with that knowledge and expertise. So I can't really answer the question truthfully and fully, because in a consultation process we don't know what will come out at the end of it, but we won't have a focused team in the way that we've had previously. That would appear to be the case from the model that's been described, and with 51% of us going, that will have an impact.
Thank you, Geraldine.
Councillor Milson.
Thank you. I've written 4 questions down. Shall I maybe do 2 and see how time goes? Well, so going back to the first time we heard about the closure of Firshill Rise and the intention to go through the transformation to a community located delivery. I think I remember at the time that there was a family who came along with a public question at that time. Quite, I mean, any kind of change, creates worry for people. But I have a memory of this family who came and were very worried about the closure of a residential option, and couldn't kind of see the future ahead for their situation. And I just wanted to sort of just get your view really on sort of an assurance that nobody has fallen by the wayside through the whole process, that people have, had what they need all through the process of transformation to ensure that they've, got everything they need to live the life they want to live.
Yeah.
I just sort of, thinking back to that knee-jerk worry that that family had. And can I also ask about kind of the stability in the workforce and how that looks at the moment for you. So I think we've been quite used to hearing from various providers and partners over the years about difficulties in recruitment and retention and the steps that various organisations have taken to address that. And I know that you have. So just wondering what that looks like for you at the moment in terms of recruiting and retention and satisfaction of staff, and what kind of career progression opportunities there are really for staff as well. Gosh,
so Helen can answer the second one, and I'll try to address the first one. So just remembering it was an inpatient hospital, so it was people admitted either formally or informally under the Mental Health Act for a designated period of treatment, but the national programme was saying that this isn't actually the best way that we can care for people, because what we should be doing is giving people support in the community to prevent them needing to go into that kind of specialist hospital. So at the time, I think what we said to you is that the numbers were very, very small, and therefore running a hospital with up to 9 beds at the time, it wasn't a viable option in terms of the quality of people's treatment. As Helen's alluded to, if people need that form of treatment, we will still admit people either into some of the mental health wards within Sheffield Health Partnership University Trust, as in it doesn't flow off the tongue yet, doesn't it? SHPU. So into those beds, or indeed specialist beds, but within the last year we've needed to admit 1 person, so I think that gives you an indication in terms of the scale of things around that kind of demand, because we're managing to keep people out. There's a major part of that process is something called the care and treatment reviews, which happen. It pulls together a multidisciplinary team to try to sort of look at alternatives to what can we do, what support can we put in to give people something as an alternative to be admitted. And often, and my psychiatry colleague behind me will probably agree with this, often a bed built is a bed filled, because it's the kind of almost the easiest option rather than trying to find the alternative supports in the community. And that's what this whole model's been about, trying to give alternatives that people get the right support and they don't need to escalate into that most restrictive level of care.
And I think if you triangulate that with the feedback that we've got, the 100% from our friends and family in art, it triangulates that I think we are getting indeed the model right, and they're feeling well supported. In terms of your second question around staffing, the national turnover for staffing is 11%, and we are slightly below that in terms of the organisation as a whole. In learning disability services, our turnover is 4.3%. So that will indicate to you how settled the team are, but actually continue to keep themselves up to date. There is lots of training and career opportunities, not only within the service, but outside of the service as well. And in fact, the team actually provide an in-reach service to the mental health services that we provide as well. So they will actually in-reach to acute mental health wards, and as well they will help our speech and language therapists are helping with dysphagia, difficulty in swallowing, across the organisation as well. So there are lots of opportunities. We are doing, because the team have co-located, so they were in separate sites, they've now co-located, and we're doing a huge piece of work there around the development, the team development, but they are a highly motivated and enthusiastic team that are absolutely dedicated in delivering better outcomes. And you know, I've said about the waiting list, and I'm sure that after we've done that data cleanse, and equally because we've just had our new EPR system, that I think we will see a truer picture there as well, as that lists are cleansed. So we have a very, I think we have a large team in art as well, and we have lots of different specialities, so we are rich in terms of the makeup of that multidisciplinary team as well, physios, occupational therapists, speech and language, art, and therapy, you know, to name but a few.
Thank you. Could I just ask a quick follow-up question about the inpatient beds since Firs Hill closed? You mentioned that one person's been admitted in the last year. Is that to a bed within Sheffield? And just since Firs Hill closed, has there been any reliance on out-of-area beds?
Yeah, it was indeed Sheffield and managed internally as well. We, as I say, we in-reach from the Learning and Disability team. But we do know that across Yorkshire, we are one of the lowest, but the numbers are not high across any area. I think the highest is 5 inpatient beds required. As Heather has said, we've only required 1 this year, and that was managed internally within the Trust's bed portfolio within reach.
Great, thank you. Councillor Mallinson?
Yeah, thank you. The work you're doing sounds, really, really important. It's and impressive. I've got some. It might be basic questions because I'm not a health person particularly, but I'm learning. But things keep changing. Not least your name, because I've just discovered that from Google that you were the Sheffield Health and Social Care NHS Trust, weren't you?
Yes,
So,
we were.
so you
Yes.
renamed.
Yes. We've become a university trust now, partnered with the university, so hence the name change.
Yeah.
We're still getting used to it, as Heather says. Yes.
Yeah, it is a bit of a long one. I'm just really curious about how you operate with the other trusts, because I don't know how many beds you have as a trust, or whether you're using the beds in the, children's trust, or the, because obviously patients will turn up at A&E or whatever, and maybe be admitted, who have some sort of medical condition and a learning difficulty. How do you become aware of them?
Well, so we don't provide services for children. We're an adult learning disability service, but we do work very closely and in partnership with the Sheffield Children's Trust as well. So the board story that I fed to the committee is actually one where the individual transitioned from the children's services to the adult services. In our bed portfolio, we provide lots of specialist mental health services, and we also provide acute mental health services and some intensive care and psychiatric intensive care as well, beds. But what we would do is look at the individual. They would be assessed and they would be placed in the most appropriate bed for their condition and requirements. So that bed may be an acute bed, it may be a specialist bed, depending on what the individual was presenting with. But actually, in terms of their learning disability, that specialism would be an in-reach for the learning disability team.
And I think what you're alluding to is when somebody's got a physical health problem and might need to hospital admission to Sheffield Teaching Hospital. So people have got every right to be admitted to those sorts of services. Of course, then it is slightly more challenging to support people if they've got behaviour that's difficult, challenging to support. So the community learning disability teams are there as an advisory service too in those instances.
Hospitals will come to you if they need to.
And the mental health liaison service that is part of this organisation operate 24 hours into Sheffield Teaching Hospital. So they will identify people who need that additional support and give advice.
Thanks for that. Just one other thing. Just to follow up on Helen's question about outreach to other minority groups such as ethnic minorities and monitoring of the data on that. Presumably you do monitor data on that, and what's the data showing you, and what work is being done to get on top of any issues that are raised?
Yeah, we do absolutely monitor the data. We have a learning disability board, project board, and we receive data on a monthly basis there. But our teams receive data as well around their outcomes, around their visits, so it's all monitored very closely. We would change particular input if required, input the data's telling us, as well. Does that answer your... It shapes everything we do, to be honest.
And I think the new electronic patient record that Helen's mentioned, which is the RIO system, actually gives a level of detail that is greater than the system we had before. So that's actually an improvement.
Okay, thank you.
Thank you.
Thank you. Councillor Lee?
I just listening to, reading the report and listening to what you say, I think there's been a tremendous amount of progress made, and obviously Heather, we go back a few years, and we know how things have moved on and changed over those years. I think it is really, really good to see all this happening, and I think I get the flavour that there's been a culture change within the whole service, because of the values that have driven, you know, the system, and that obviously drives actions and motivation. So it's really good to see that. I can feel it coming across. That's what I wanted to say.
Thank you very much. Thank
that's
you.
Fine, no. And I just suppose one of the things is about inequalities, which is health inequalities, mental health inequalities, social isolation. All those things are really important. And some of the hardest problems to tackle, it's not easy when people can't do things for themselves. And I just wondered how you're monitoring that, and how you see that progressing in the future, how that is going to pan out in terms of particularly social isolation, not just for the individual person with learning disabilities, but for their family. I know somebody once said to me, a disabled child or a disabled adult is a disabled family.
Yeah.
So, yeah.
I'll answer part of that, and probably between us we can address that. So just as one example, Helen mentioned the earlier deaths, and we know from national statistics that people with learning disabilities die up to 50 times. They die 50 times earlier. No, I'm saying it wrong. They are more likely to die, 50 times more likely to die by the age of 55 compared to the rest of the population. So that's a really important area of health inequalities. So we're doing things like the flu vaccination campaign. We're actually hitting more people with a learning disability for the flu vaccination than we are the rest of the population, because of really concerted effort with the community learning disability teams, with MENCAP as a partner, and with GPs and primary care. So that's one example. Annual health checks is another example. We've actually increased the number of annual health checks by about 10-11% since last year, and that's despite the doctors' strikes and the early presentation of flu. So we're getting into a lot of that work around health inequalities. We've got a physical health improvement group that we have been chairing from an ICB, but as part of that legacy is what happens when we're not here, or 51% of us aren't here. We've got colleagues in the teaching hospital, local authority, and Sheffield Health Partnership University Trust are part of that. And that's looking at things like the learning from deaths of people with learning disabilities. It's looking at things like the access to screening, so bowel screening, work around breast screening. So we're doing a lot of work around that sort of health inequalities through those pieces of work. And even when we're gone, I would hope and anticipate that that work continues through our partners.
Absolutely. Okay.
Thank you, Mary. Thank you. Thanks.
Councillor Belbin?
Thank you. I'm relatively new to this committee, so apologies that I'm not familiar with your journey, perhaps in the same way as other members of the committee are. But I must say that any service that is getting 100% positive friends and family feedback is clearly doing something really right. So that sounds fantastic. I did want to come back to some of the involvement and voice work, though, and I think, if I'm understanding correctly, that you're indicating that probably some of the stats around ethnicity in particular were perhaps not involving people from all communities at the moment. I'm really interested in that involvement work and how we're using those voices too. And it's a good example here around the how you've improved communications. I just wondered, you've been talking about as well, you know, alternatives to inpatient treatment, and how much are we involving the voices of the service users there? And is there, if we are not involving people from all communities, you know, there will be different alternatives for people from different backgrounds and cultures, and is not something that we need to focus on to ensure that the service is really truly inclusive and is tackling those inequalities.
And we are absolutely committed to do that, hence the framework. And I think even in our learning disability, I know we've got the partnership board, but the trust board or project board, we make sure that I co-chair our board and not with a learning disability, somebody that suffers from a learning disability. So we make sure that round the table there is a voice at all times round the table. We didn't have that always, and the framework now is providing. I know that we have, as we've heard from Helen, we've still got work to do there, but it is a much wider, and through the partnership board as well, there is a much wider voice there, but we're really keen to have people with lived experience actually sharing their journeys as well, and actually what made a difference to them, what was missing, how we could have filled that gap. So, but as our main desire and ambition is to ensure that everybody has access to mainstream services. That's where we need to get to, not that we're having to target specific areas. We want accessibility to every mainstream service, and that's our ambition.
Thank you. I think I'll go on, Ruth. I've got a question, but I'll let you ask your two first. Go for it.
Okay, thank you. Just following on about the co-production, just wondering what that kind of looks like in practice, aside from board meetings. Something that strikes me about this is that where if someone's had, say, an acute hospital admission, they might be asked for feedback on at the point of discharge, and that's kind of a point in time and one experience that they've had and one journey that they've had. But obviously a lot of people are accessing these kind of services over a long period of time. Yeah. So it's not just a one-off experience. It's more like how does their contact with these services evolve over time? So how do you handle that ongoing co-production?
So the co-production we don't just wait until somebody's had an experience at the end. So like your example, they may have had an episode of care in the teaching hospital and then give an experience, you know, how it was for them, etc. But we're doing, and that is ensuring that there are people round the table when we're actually looking at services, so like the prevention, like the bowel screening, actually, what does it mean for them? You know, what time would be convenient? How accessible? Is it better in a GP surgery? Is it better somebody come into home? Is it a combination of both? So actually you're producing and designing the service actually and then evaluating it at the other end. So it's not waiting. And it's making sure there's involvement right from the beginning, and actually, you know, even with the opening hours, being able to, you know, be flexible in the service. It was through that listening and through patients, not patients, but individuals with learning disabilities and their families, not just the person themselves, but their family and wider carer. Actually, what that meant for them, what did it look like? What do we need to do differently? So it's making sure that you're producing and co-producing along the way, not just at the end when you're evaluating.
I seem to recall, and I might be blowing a trumpet here, but when we presented last time, I think you particularly commended us for our engagement work because we'd gone out and done group activities, we'd reached out into communities. That was also picked up by the North West Clinical Senate that we also had to present to. They could see that level of engagement, and particularly the materials and the approaches that we took. And I think learning disability services have those kind of approaches at the heart, actually, because accessible communication is such an important part of that kind of approach and that particular population. So I think that would be something that the clinicians are, it's actually bread and butter to them to be reaching out. I do think we need to think about, are we getting into some of the communities, and that can be a piece of work through your framework, can't it?
And I alluded to our annual report as well, which we presented at our annual general meeting as well, and it was through feedback that actually was like, this is great, but actually it's not great if it's not accessible and readable. So we came away from there and immediately worked with MenCap, Sheffield Voice and the Learning Disability Partnership Board to actually make that an accessible and readable document for all. So there's learning opportunities every step of the way.
Thank you. I just had a couple of questions. It's really good to hear that the waiting times are starting to go down and that by the end of the financial year they'll be around 80. But I just wondered what level are you aiming for? What sort of would be considered?
Zero.
Zero.
Absolutely. We're aiming for zero.
Just sort of what sort of things are working and bringing the waiting times down? What are the things that are making a difference? And I'd also just be really interested to hear a little bit more about the new programme you mentioned, focusing on reducing admissions of hospital with the autism focus, and just sort of what that's going to involve, what that sort of practically will look like. I'd just be interested to hear. Thank you.
Yeah, do you want to do the autism? So in terms of the waiting times, there's part of that around actually the waiting well, so making sure that we're touching base with individuals while they're on a waiting list and making sure that there's contact. I don't think our waiting lists we don't have large waiting lists anyway, but I don't think there is we're reporting now because of the quality of our data, and that on the new system will support with that. I think equally we don't have a true version. We may have somebody referred and working in various clinical areas, so we may have somebody referred to eating or eating service or dietetic service, and we may have an individual that is being seen by the physio at the same time, and it's a bit technical, but they will have an open case, an open for the dietitian and an open case for the physio, and actually sometimes they forget to close that down, so it looks as though they've been waiting for that service for a particular length of time, and it's not a true reflection. But I think once we've got a true foundation, and we'll have much less waiting times. And as I say, they're not in benchmarked across other learning disability services, but our waiting times are very, very low.
And the autism work, so Helen and I have identified this as an area that we need to really drill into. We've already added an autism crisis nurse into Helen's organisation to work particularly in people with crisis. There's a diagnostic service that's been in place for a long time, but there are waiting times for that, and you know about the kind of autism, ADHD type waits nationally as well. So what we're trying to do is pull together what we're calling a kind of a virtual team, and we're going to put an additional nursing post into that is the intention, so that we can bring people together to try to get into that prevention of admission work, because at the moment it's not quite falling into anybody's task. So somebody might present to community mental health teams, they have a degree of knowledge and understanding about autism, but autism specialist advice at that point would be really helpful to try to prevent that admission. We have something called the senior navigators. They sit in the integrated care board at the moment, and what we've been doing in the last couple of months is actually trying to sit them a little bit more into the SHPU trust, to actually have those clinical staff that can support the wards and support the community teams to, again, for that prevention of admission.
And just to add to Heather's bit as well, we actually are working really closely, triangulating up both with primary care, the acute, the children's, and yourselves, so that if there is a need, if there is a specialist question, we can then reach and discuss that and pull together a professional team really quickly as well.
Thank you. You've got one final question, Councillor.
So, sorry about this, Chair, but I meant to ask it earlier on. On the case study, One of the outcomes was continued improvement to friends and family tests. Could you just elaborate a little bit more about how those improvements have been made?
We're actually at 100% our friends and family test, but we're not complacent. So we will continue to ensure that we get as much feedback as possible, because it does actually impact on the service we produce and any changes but it's equally as well about learning what we're doing well and sharing that good practice as well. So it's not all about change and things, it's about actually celebrating some of that success as well without becoming complacent.
Thank you. Thank you so much. We've only got 2 substantive items today, so it's been nice to have time to have a proper discussion. So before I just move on to the recommendation, I just thought it'd be worth just pausing momentarily to think about if we want to do anything next. And I wondered maybe as part of our work programme for next year, it might be nice to have you to come back and give us a further update of how things are going, if that was okay.
Yeah, I'd be very happy to do that, absolutely.
Committee be happy with that?
Obviously, the ICB may or may not be part of that, depending on our structure by that point. But
yeah, we can consider that.
Yes.
Sort of in due course. Yeah, brilliant. So I'll move on to recommendation. So the Health Scrutiny Subcommittee are requested to note and discuss the presentation report of the Sheffield Health Partnership University NHS Foundation Trust in response to their request for an update on the future of health services for adults with a learning disability in Sheffield. We're in agreement that we've done that? Brilliant. Thank you so much for coming today, bringing your report and answering our questions. I think before we move on to the next item, we're just going to take a short break of about 5-10 minutes before we move on to our next item, if that's okay with everybody.
Can I just thank everybody? Thank you very much.
Yeah.
It's been really welcome. Thank you.
And thanks for your interest in this population. It's really good.
Thank you.
Thank you.
Great. So we'll just take a pause here. Brilliant. Thank you, everybody. So we'll move now on to item 8, which is on the Healy and Gleedless 24/7 mental health project. Sorry. I'll ask the officers to introduce themselves, please. Thank you.
Hi, I'm Professor Tim Kendall. I'm the National Clinical Lead for New Models of Mental Health Care based at NHS England, but I'm also consultant psychiatrist to the Gleedless and Healy pilot, which is funded nationally.
And good morning, everyone. I'm James Sutherland. I'm the Integrated Change Programme Director at Sheffield Health Partnership University. Sorry, as colleagues earlier, still getting used to the new name. I also work alongside Tim as a National Advisor to NHS England, where I'm the National Specialist Advisor on Community Mental Health Transformation. But thank you for squeezing us onto your agenda today, and it's great to be here.
Great, thank you. Would you like to give us your presentation, then we can open up for some questions and conversation? That'd be great.
Thank you.
Great. So I thought I'd just give a brief introduction to the national programme before we then talk about the local one. So in the 1960s, we had about 120,000 mental health beds across England in roughly 120 asylums. They've been gradually shut. So in Sheffield, we're between 1,500 and 2,000 beds. That's come down now in Sheffield down to 60 acute beds. So it's been a massive reduction in beds. And during that time, the private sector has expanded, so they've now got about 8,000 beds, whereas the NHS has got 18,000 beds. And although we've moved more into the community, we still have got we've got a growing use of the Mental Health Act, to the point that our beds in Sheffield are almost all full of people under the Mental Health Act. And if I was to give my sort of diagnosis about what the problem is with our inpatient units, is that they are predominantly there for risk. So if someone is a risk to themselves or to others, they tend to end up in a psychiatric unit. These units try to have very short stays as far as possible. That's often quite difficult with people who are very ill. And a lot of people would describe these units as frenetic, overheated, people coming in and out very quickly. And we're spending more and more money on these beds. So whereas these beds used to be down at between 10 and 20,000 pounds a bed per year, the cheapest psychiatric bed is now about 200,000 pounds per year. The most expensive is closer to £1 million. Yeah. So if you go to an adolescent psychiatric intensive care unit, you'll pay more than £3,000 per night, which is shocking. So there has been a huge growth in community mental health services in spite of that. And I was National Clinical Director between 2016 and 2023. During that time, we increased the spend on community mental health by 3.3 billion per year. So that's now, the overall spend is up at 14.7 billion, but we're still spending much, much more on that inpatient unit than we should be. Now, in the community, everything you'd think was looking good, but the way that community services have grown is that they've developed more and more community teams. So if you go to Gleadless and Healy now, there are 13 different community teams that serve Gleadless and Healy, as they do all over Sheffield. So we've got primary care mental health teams, community mental health teams, NHS talking therapies teams, home treatment teams, crisis teams, etc., etc. Now, all those teams know exactly who they don't see, better than the people they do see. So people going into community mental health anywhere in the country, it's a bit like going into a pinball machine. You get bounced from team to team to team. And sadly, 50% of people don't get a service at all. And that's true for children as well. So in that context, when I was National Clinical Director, you will remember that there were two television programs, one on Panorama and one on Dispatches, which were horrifying shows of what was happening on the inpatient unit. And I was asked to appear in front of NHS England Public Board to give an explanation as to why we were still seeing what we thought had died with the asylums. And I was told by the non-executives, publicly, it's on record, that they believed that our system, which had not really changed effectively for 50 years, with intensive inpatients and rather chaotic community services, that was broken. And they said, go away and come back, having looked abroad, and come back with a new model for mental health care. So that was why. So we looked abroad. We looked at places like Trieste. We looked to Brazil, which have shut all their asylums and not opened up hospitals instead. Northeast France, various others. And what we did was, with a group of service users, was took those models and extracted what we thought were the key principles. And they're based on trusting relationships, continuity of care, based within their neighbourhood, integrated with the voluntary sector and primary care, that they don't use coercion, that they're co-produced with their community and people with lived experience, that they're there 24/7, and that they don't turn people away. Now, it's sad to say that our community services are not like that now. So I got 30 million from NHS England. We put out a competition. We got 37 applicants. Basically, it was to say, if we gave you £5 million, could you set up a service that fulfilled these principles? Yeah. And with a population of about 30 to 50,000 people. So we got 37 applicants. We shortlisted those to 22. That was then brought down to what we could afford, which was 6. And one of them was Sheffield. I wasn't involved in deciding if if it was Sheffield or not, we had a way of making sure I didn't see that. But Sheffield, I mean, the bid was done by James, or he led the bid. What's happened with the other, perhaps say what the other sites, one's in Lewisham, one's in Tower Hamlets, one's is in East Birmingham, one's in Sheffield, one's in York, and one is in Whitehaven. So each of those have been, for the last 18 months, have been gradually setting up. And we put in an evaluation with Ipsos Mori, the Centre for Mental Health and University College London. And the way that most of these places function is that they take everyone who comes in, and each morning, instead of having a referral meeting where you decide whether or not a patient is suitable for your service, you decide which person is best suited to seeing this person. Is it someone from debt counselling? Is it someone from social care? Is it someone from social prescribing? Or is it mental health? Yeah. So we're all in the room together. Now, they're all at different phases of development, but I'm pleased to say that the Health Select Committee have done a review of all of our neighbourhood sites. It's a fantastically positive report which says this is the direction for mental health. And we have got 3 more sites are being set up now. And we've just, a month ago, we understood that we've got 316 million capital to help other sites set up across England. So it's my view, it's my belief that this is the future of mental health, but it will take a lot of planning and sharing. I meet with all the sites every 2 months. We need to carry on doing that to make sure that this genuinely works as a new model of community-based mental health care, which is not like a little hospital locking people up. So, James.
Thanks, Tim. So to put a bit more of the detail around Sheffield, I appreciate we've probably given you quite a substantial amount of background information reading. We don't shy away from that. I think it speaks to the volume of the quality of the co-production work, the thought, the thinking that's gone into the work thus far. I'll try and pull out a few key points, but then really keen and conscious of time that we can open it up to the richness of this wider discussions. So as Tim alluded to, as part of the selection process, we had to work within a footprint of a primary care network with a population of about 30 to 50,000. So within Sheffield, we did population health mapping. We might call it population mental health, looking at what are the needs in different communities around the city, from age, from demographic profiling, through to wider determinants of health, so factors such as housing, debts. And we narrowed that down, and Leadless and Heeley was an area that really shone out to us. We know it's got some of the highest inequalities in England, and that data's within your packs. It's traditionally had quite limited mental health accommodation or estates there. We note that residents previously needed 2 bus journeys to reach the nearest alternative mental health site. If we drew it on a map, it looks about 4 miles. That doesn't sound a lot, but the public transport infrastructure. Also, did people actually have the affordable means, the income to be able to afford to travel there? Yet one of the GP practices in there, we know, has one of the highest rates of individuals that would present to our urgent and crisis services, so huge levels of need. The area also has the highest proportion of mental health personal independence claimants in Sheffield. We know that education and training needs are great in that area. So these are things that are contributing factors to mental health, but equally mental health can't solve them on their own. We need to be working, as Tim said, collaboratively more with partners. And I think the strong community networks and also the regeneration activity taking place around Leadless Valley made an ideal pilot site. We challenged ourselves as well to do something to try and be truly transformational. We didn't just want to find a building and, as Tim said, take a chunk of those 13 teams and put them in. That would have been on the journey of transformation, of bringing care, support, treatment closer to people's homes, closer to local communities. We challenged ourselves to go further, to say, who are we making meaningful connections with? How are we embedding with the local community? And when we were developing the bid, we explored different areas to say, well, how do we destigmatise mental health, have mental health almost on the local shopping precinct high streets that people can drop in. But also we know if we have a big sign that's mental health centre, that's a barrier to entry for some groups as well. So how do we build this into existing community assets? So that led us to Newfield Green and the Newfield Green Library and the Terry Wright Community Hall that we know we're in need of investment, really important community assets. So with the pilot funding, we thought, let's keep public money within public services, with it being a council asset, but let's try to reimagine how do we wrap mental health services around the footprint of the library, the Terry Wright Community Hall, being really clear to say we're not losing community space, we're adding to it, but equally in doing so, we wanted to make sure as well there that those wider links, there is the baby and toddler group, there's the over 60s tea dance, English as a second language, so many things that are already taking place in that community. How do we add and contribute to them, and also use some of our investment to A, further develop, or B, if there are gaps. So one example of that through the co-production work was where we heard access to debt, money and financial advice. There was not enough sufficient resource. So we were already working with some of our funding to build additional capacity for that area as well in response to what people have told us. We also wanted to make sure that each site was fully served by the established bus routes, or also what we're also seeing is people who are actually within walking distance for many staff and many residents as well. In terms of that co-production work, it's been very extensive. Over 500 people who use our services and local residents have participated through over 20 face-to-face events online. We've done mood boards, listening sessions, mapping questionnaires. We've interviewed people that have been from the area that might have been on our inpatient wards. And all of that is built into us developing an ongoing, you said, we listened, and our commitment towards actions. We've got a strong partnership with Sheffield Flourish, Healy Trust, Synergy VCSE Alliance, the Gleelas Valley Tenants and Residents Association, the Regen team, and on the list goes there. In terms of our approaches, it's taken us a little bit longer to mobilise. We're now in the midst of building work that's due to complete early next year. We've made a lot of really positive connections and friends along the way there. And actually it's been really nice to be able to do things and co-design a new future modern space that's not just for mental health, it's for the whole community, and the community really being at the heart of that design process as well. In referring back to colleagues in the previous conversation, we've challenged ourselves as well around some of the development of new and different roles. So we've recruited some roles that are called senior lived experience practitioners. So they're individuals that have lived experience of mental health. In terms of career development, in some areas there can sometimes be a little bit of a glass ceiling at the level of those roles operate. From the outset, we've got 3 of them that they work partially supporting people who use our services. They also form part of our senior leadership team. Also through the co-production work, we've heard as well loud and clear about the importance of peer support roles. So again, we're investing some of the money into additional peer support roles, but asking voluntary sector and community partners to host those roles, and talking back to groups who may be underrepresented in some of the mental health services. We know a lot of community groups have got really, really strong links. Also, they're from that community where people, so we need to work collaboratively with them, but actually have them hosting roles as opposed to it always traditionally being through the NHS. We've had really great support from our local councillors in that area, from the Green Party, from Marianne Elliott, Alexi Diamond and Paul Turpin, and obviously continuous collaboration as well with Sheffield City Council officers, Regen and Adult Social Care. As Tim said, we've got about £5 million of non-recurrent funding. Broadly speaking, that breaks down into about 34% of it going into refurbishing buildings, about 28% new staff, mainly peer support and lived experience roles. 15% go into having a crisis cafe and 3 hospitality beds, and about 13% into VCSE partners. I think the benefits that we want to see from this is very much around easier local access and greater prevention and early intervention around crisis cases, about people being able to drop in without the need of an appointment. You could be at Newfield Green buying a pint of milk. If you need to check in around your mental health, you walk into a generic community asset. It's easy to do. Everyone gets a warm, welcoming and positive response. Shorter inpatient stays, with fewer A&E attendances linked to mental health, and also fostering those really, really strong links between the NHS, the voluntary sector and local residents. And hopefully through the pilot, it builds the legacy model for other Sheffield neighbourhoods to replicate and do more of this in the future, and as Tim said, with those opportunities. So I think in summary, this centres a real genuine partnership between professionals and the community. It's co-produced, locally rooted, and is already strengthening mental health support right where people live. Thank you.
Thank you, that's great. I'll open up to questions now. I'll start with Councillor Belbin and then I'll work my way around everybody, I think.
Thank you. The work sounds really, really exciting, and I know at Strategy and Resources Committee last week we took through the Gleadless Valley Master Plan, and you know, you've obviously talked about the links there between what you're doing, and it's, I suppose it just feels to me there's a massive opportunity there, because it's not just about the services that you are providing, and I think the way that you have gone about that in terms of co-production sounds really excellent, but there's a real opportunity to reshape the valley itself to support people's mental health needs. So it's not just about the clinical support or the health support, if you like. It's really about how it can make a change to the entire area. So I'm really interested in how you're contributing to that side as well. I mean, you know, you talked just there a little bit just how things like bus routes, for example, have restricted people's access to health in the past, and that's one of the projects that's being looked at under the regeneration plan. Access to nature, all those kinds of issues, you know, obviously housing, employment, all those things which we know are, you know, massive contributors around mental health. How is your project contributing to that wider project as well? I'd be really interested to hear.
So, thank you, Councillor Belby, for your feedback. And yeah, I will confess, I did see, it was lovely to see Lara and Matt from Gleadless Valley Tara last week, and the links there. And we're working really, really closely with them. You know, the challenges that are faced, we shouldn't, you know, we can't play them down. They are significant. But the only way we can do this is through the partnership working together. With our funding, we've made sure that we're investing additional money. It's not just going into NHS clinical services, it's going into the voluntary. So we're working with Regen. We've got links with employment opportunities where we were creating those peer support roles and similar. That was actually looking, how do we create local employment opportunities there? And equally, tomorrow we've got a meeting with wider officers in the council around the training and education, because for some people, that's a really important aspect to it as well there. So I think it's one we're committed to, being a strong partner. Also through Health and Wellbeing Board and similar situations where Sheffield Health University, can't get it right, can I? Sheffield Health Partnership University, SHPU. And I think there, how do we also step in to try to support, to advocate for and be an additional voice around improved public transport or housing or similar, because they're a tough nut to crack. One person can't do them together, but the more we collaborate and see ourselves as one, has to be the best option.
It is worth saying, though, that whilst we are collaborating with the voluntary sector and social care and primary care and so on, we are nevertheless focused on mental health as one of the key burdens that I think a lot of people who have got a range of social problems face. I used to, for 15 years, work with homeless people in Sheffield, providing mental health input, and there it was completely a collaboration. You couldn't, mental health was one part of the problems that they face. There's also, you know, debt, you know, not having a roof over your head, etc., etc. So we're quite happy with the fact that we're working with mental health plus all the causes of mental health.
Thank you. Helen, shall I ask you a question?
Thank you for that update, and I know how much work has gone into it and how much work it actually takes, and just the kind of different layers of activity that you've described. Actually, it's long-term work, and it actually plays to the things that a lot of us care about, and it's good to kind of to get an update on where things have got to, recognising that actually it does take a longer than probably most people would anticipate on a Gantt chart or a timeline. I think it's great, and I guess given that this is funded until 2027, my question is about the planning and assessment of continuity of support for people in that area who I think you've done a lot of work to bring them in and build trust, and when you do that, then there needs to obviously be that continuity in terms of what's going to be available after the funding stops. And just interested in what you've been doing to think about that as the kind of that sort of next step on.
Every site, all 9 sites now are all thinking the same. What do we do next? So, as I said, for each of them, currently, Gleadless and Healy have got a primary care mental health team, a community mental health team, an NHS talking therapies team, a crisis team, a home treatment team, older adult versions of those, assertive outreach team, early intervention and psychosis team, etc. Now, what most sites are now doing is that they're taking the core of those teams, so that's community mental health, primary care mental health, home treatment, crisis, and saying if you put all of those in your centre, you actually have enough people to do all the work 24/7. And you may think that's a surprise, but the numbers involved, if you just put those together for Gleadless and Healy, you're talking about in excess of 50 people. So I don't have any doubt that we've made a real error nationally in investing in so many teams, which I have to say I think is the way the health service works, which is politicians come in and they say they have a shopping list, they want a legacy, so they'll set up a new team. So I was involved with one where we set up new teams into schools, so school-based mental health teams, and they've been rolled out across the country. It's going to be about £500 million per year, and everywhere will have a mental health support team. Another one I was involved in was helping to spread primary care mental health teams. It's great in the sense that you get a headline out of it. You know, so the perinatal mental health teams, when I started, we had 15% of community perinatal mental health teams across the country. We now have 100%. These are headlines. They're great headlines, but they neglect to see that it's now fragmented community mental health. This will reunite community mental health. That's where the future is.
So I think just to build on that point as well is we've got, it's really, Sheffield's very fortunate. It's a great opportunity for Sheffield to be a pilot site. Some of that is test and learn, and sometimes we are dealing with known unknowns as well there. So for example, when we open with the 3 sort of guest bedrooms that are like a safe space, we're highly confident and optimistic that they will have a real positive impact. We don't have them at this moment in time, so we need to evaluate. So there's some things we need to look at. It's our social and moral responsibility, though, as well with the pilot, to avoid a situation that sometimes in the past have happened elsewhere, where it can be boom and bust. So sustainability of, as Tim said, teams coming together, still being able to work there, that existing resource, how we're working across the local community, that's our responsibility, and that's been at the heart as well, to make sure that what we're trying to do, we've got one eye on the sustainability and trying to forecast almost the best possible outcome one maybe in the middle, and even considering the worst case event to make sure there is a sustainable model that will last long beyond March 2027.
So, I mean, that's really helpful. Can I just check then, particularly what you were saying, Tim, about the kind of co-location and what that actually creates? What will compel that continued collective working, and are you looking at what are the sort of mitigations in case actually that doesn't continue to happen beyond 2027?
We are absolutely committed to this going beyond 2027. As I say, there's now 316 million capital to set these up. The model will be, how do you get these teams to all work as one and not bounce people around the system? So the people investment is already there. It's the capital. It's a bit like suddenly deciding that you're going to provide general practice or primary care, and a bunch of doctors leaving the hospital and thinking, where are we going to go? Well, the obvious place is in the middle of your community. And we've got all these teams, none of them are based in the middle of their community. I mean, some of them are based up in hospitals. You sort of think, it's not much of a community service if patients have to travel up to a hospital to get your community care. So this is moving all those community teams out into the community, into their community. So that I think is a completely sustainable model, except the capital. So we've got enough capital for 170 new sites. I think we need about 1,200 across England. So it's a 10-year plan.
And I think, sorry, just to build confidence, Helen, to your point as well there, within Sheffield Health Partnership University, got it right that time. It is a strategic priority, and seeing this very much as the future way with strong exec supports and backing as to how we deliver services moving forward. As Tim said, we're not jumping in one step from today's state, because it relies on capital, it relies on planning, but we're already considering where next in the city and starting to undertake, at the moment, quite high level, building on data, needs, demands, starting to work with partners to identify potential suitable options around estates and similar there. So it's still in its relatively early work, and in the new year that will start to ramp up as well. But I think that's another sign of commitment that as an organisation we do see this as the importance of this, but really see it as the future way of integrating and providing our mental health services.
Thank you. It's really good to hear about the work looking at the rest of the city. I'll move on to Councillor Madison's question, please. Thank you.
Thank you, Chair. Yeah, it just seems incredibly exciting and really welcome. You know, bringing people together to work collaboratively is the way to do it. Hopefully there'll be a cultural change. When they are working together, it'll become impossible to think of doing it any other way, which is, I guess what you're aiming for. So my computer's just turned itself off, and my question is, I think often these things do come down to sort of value for money, which is a terrible thing to say, because it's obviously doesn't matter about the value for money, it's what you're doing in the community and how effective it is. But are you going to, is there any way, I mean, this is a very difficult thing to do, I'm sure, but is there any way to measure the impact in terms of the savings on other services, whether it's A&E, hospital services or whatever, and are you going to be doing that, and just to demonstrate the effectiveness, the financial effectiveness of the service?
It's our expectation that this will have an impact on the use of beds. So, and two key things to bear in mind. Trieste, which did this in the 70s, and I went there for the first time when I was a junior doctor, now a resident doctor. I went there in the 1980s, in 1985, and spent 3 weeks going around their services. at the time I was working in Middlewood and the Northern General Psychiatric Unit, and I came back thinking, I cannot believe how different those services are. And they had no hospital. Yeah, they got 6 beds, community beds in each of 4 mental health centres around Trieste. And they've been like that for the last 50 years. I mean, it's incredibly impressive. The Health and Social Care Select Committee went over there, and so the point is that whereas we're spending around about 65% of our inpatient, of our money, of our total mental health money, 65% goes on inpatients who cater for 4% of our patients, and 35% goes on the other 96% of our patients. So if we can make any inroad into that, we are saving money. So you look at the ratio of spend per person bed on inpatients, it's 30 times bigger than the people are getting out in the community. And in children's services, it's 100 times bigger. So anything that will reduce the use of beds will save money. If you 3 adolescent beds will get you a full community team. So that's one thing. Second thing is that there's been a trial recently of open dialogue. It's just coming up for publication. I've seen all of the data, and they use many of the principles that I've highlighted, but without the centre. And they've got a 50% reduction in use of bed nights. So the calculations that we've done from that is that you could save about £1 billion. So I think the big impact, and this is what we're looking for, is a reduction in the use of beds.
And I think building on that as well is, in the previous agenda item, there was talk there about A&E or emergency department presentations. We know there are 492 presentations from people from Leaders Valley in the previous 12 months alone. Are we going to get those down to 0? The answer is no, because in the hospitals, they have a mental health flag. In A&E, some of those, so it could be, for example, if someone had self-harmed, they'll have triggered the mental health flag. But if they've got cuts, their physical health need of having a wound clean, dressed, potentially stitched, or it could be someone with chest pain and anxiety, let's say. The hospital, A&E, will need to examine some of the chest pain. So what we want to do is identify how we can try and improve some of those rates. As you were saying, Councillor Mallinson, about firstly showing that value for money, but also remembering that there are other important factors that we need as well about what's people's local experience, their stories, our staff. And we're already seeing a lot of positives about that co-location, working more collaboratively, and also linking with the local and national evaluation work. There are 3 nationally recommended patient-reported outcome measures. So as Tim alluded to, one is the dialogue scale, another one called REQUAL, another one called goal-based outcomes. They're evidence-based so that we can actually use those to track someone's journey. So from when we first see them throughout their journey to perhaps a point there where they no longer need mental health service support, but they're being supported through community groups or similar, but we can really evidence that distance travelled and not just looking at health, looking at those wider determinants of health as well.
Thank you.
Great, thank you. Councillor Milson?
Oops. Thank you. Yeah, phenomenal to hear about the progress of everything. And I was going to ask about the the flash word pilot that Helen's already asked about. So, it just makes me massively nervous seeing the word pilot on anything, because something amazing happens, it has money to make it happen, and then it disappears without trace. But it does sound as though you're absolutely determined not to let that happen locally, and that the national direction of travel is going very much the right way on that. So I'll leave that one.
It's actually in the 10-year plan. So it says that mental health will move to a neighbourhood-based model of mental health care.
Yeah, supported by the right funding and the right mentality. So that's
yes. I mean, we'd ideally like more funding.
wondered one. But I have got a couple of questions. So in the You Said We Listened part of the report, which is really brilliant that you've included it. So thank you for putting that in, because you know, sometimes we spend time asking in this committee about how did you do co-production, and it's right there in the report. So that's really good. Thank you. And really interesting to read through people's comments. There was one that stood out to me where someone asked about what volunteering opportunities there might be with the new centre in operation. I wondered if you got any thoughts about that, because there wasn't anything in the response. And just thinking, you know, mindful that for some people, being useful and being helpful to other people is so important to them, and you know, maybe is the thing that keeps them in good mental health themselves. So it does seem there's a bit, you know, there's big scope there potentially to use the energies of the community and help people channel what they want to contribute in an informal way. Understand that the informal part of it can be a bit scary for organisations, certainly is for the council. I think, you know, dealing with people who haven't got the qualification or the badge or doesn't belong to that organisation can be really frightening to open the door there. But I do think there's massive opportunities. And then also I've got a specific case study that I'm really intrigued to know, how would this person, a hypothetical person, experience things differently in the Healy setting. So I'm going to give you somebody who is suffering a long-term complex PTSD and is still on a waiting list for treatment for that. At the same time, they were made redundant from their job, not in work, which is something that they resent a lot, and also have developed respiratory and cardiac problems and are on waiting lists to have those assessed as well. So this is a person who is held on multiple waiting lists and doesn't feel important to anybody, doesn't feel like they're anybody's priority, and is really suffering from that mentally. So what would be different for that person once all this is up and running?
Okay, so first of all is that if they need help, then our door will be open for them to either come in, or if need be, so if they've got physical health problems and can't get to see us, we will go to see them. Yeah. So the first two patients that, it was the chief exec asked me to do this actually. I wasn't planning on being a consultant for this, but the first two patients that I saw, both I've been seeing them at home because for a whole variety of reasons they've not been able to get in. So if that was a problem, we would see them at home. And we've got, obviously we've got contact with people who could help with, they're now redundant. Question is, could they work? And we will have access. We don't immediately for individual placement and support. So that's the best evidence-based support and employment program we've got. So we would be helping them with their complex PTSD, and we wouldn't have a waiting list for that. We already have got rid of our waiting lists in Clevis and Healy, so nobody is waiting for mental health care. And I think we're the only community team in Sheffield who can say that. So they wouldn't wait for anything. We would help them with their employment, and we'd help them with their mental health. Now, complex PTSD is complex, obviously, and I think people with that diagnosis have often been treated really quite badly, and when they get into A&E, they're treated equally badly. So it's our mission, if you like, is to make sure that people like that are helped, that their needs are addressed, and that will include A&E. So at the moment, our team meeting, which we've got this afternoon, we're going through, we've got a list of everybody in Clevis and Healy, where they are around the system. Yeah. So if they went to A&E, if they're in the decision unit, if they're in the inpatient unit, and our aim is to go through and gradually, as our capacity increases, is to find alternatives for what they've got. So somebody was admitted the day before yesterday. We're hoping that by tomorrow we'll have helped get them out of hospital and back into Gleaders and Healy. So that's the kind of approach. And obviously we're very close to the primary care. The GPs, we've been meeting with them and so on. I would envisage that we would have a multidisciplinary plan around their physical health, their social care, their work. This isn't, mental health and what I do as a psychiatrist is a small part of the bigger plan for all our patients.
And Councillor Milson, to go back to your first question around the volunteering opportunities, absolutely we do want to support, to promote some of that. We should be mindful as well, even the Newfield Green Library itself is a volunteer run and led library. As we move forward into the new year, we've been, now we've got a bit more certainty over where some initial voluntary sector and community group investments are going to start, so that will create new volunteering opportunities. And I think it's one that we really need to listen to people to find out, because volunteering itself is a form of work. We shouldn't discount it as that or put it in its own separate box with things there. So absolutely, we're committed to that. And we want to see that grow and develop, and hopefully as we move forward with even more opportunities that we haven't launched yet with different community funds, there's volunteering opportunities for people who wish to contribute through volunteering should only just develop and grow. And I think we need to consider that volunteering, not for everyone, but for some people, is how we link that to training and education as well, because the volunteering can be the work experience bits, but then we also know around 24% of people in the Gleaders and Healy area will leave school without any formal qualifications. How do we actually start to see either volunteering, training, education, linking those bits together? This is a longer term game, but actually if it helps people to progress into the sustainable or types of employment that they wish to, it's going to take time, but we need to start somewhere with it, and this feels like a really sensible starting point.
Thank you. Councillor Harris?
Yeah, I've got a whole list of questions, but I don't think we've got the time. I would like to ask a lot more questions. I'm very fascinated by this pilot, being a neighbouring ward council in Great Park Ward, which covers Woodsey's here, and we have pockets of deprivation and ill health in certain parts of our ward, despite being sort of the middle across the city. And I'm very well aware of the... well, I wanted to ask about the catchment. I'm familiar with the area, having in a previous life represented the old Healy ward, which covers large chunks of Gleaders Valley and Healy, Mearsbrook, that sort of area. And I'm familiar with the Newfield Green Library, Terry Wright Centre, and the fact that the area has a well-developed VCF sector, and I'm pleased that you are working with Healy Development Trust, who have a lot of experience in the Healy City Farm. I don't know whether you're working with the Healy City Farm in terms of, sort of social prescribing, that kind of thing, and all that sort of thing. Can you just... I mean, I'm not expecting a long response, but I'm just wondering, the other question I have is, a lot of that falls within the South Local Area Committee of the Council. I'm just wondering whether you do any work with the South Local Area Committee officers, because I'm sure that we would welcome you coming along to a public meeting at some point if we have that.
I'm sure we'd be delighted to come to a meeting. I don't know if you've done any with them.
We've been to one, I think, in the early days. We'd be delighted to return and probably provide some updates. I think a lot of our focus probably has been through Regen, but I think with the local area committee, we'd be delighted. If anyone could facilitate that, you tell us, we'll be there.
Okay.
It's worth saying that if we look ahead 10 years and we're getting probably 12 of these centres around Sheffield, we've got to think, how do they all work with each other? So at the moment, if someone comes in to see us and they're not within our patch, we think it's our job to try and get them the service they need in their patch. Yeah, that's going to be much more straightforward when you've got neighbourhood mental health centres everywhere.
I was wondering how you are managing expectations in terms. It sounds a very, sort of project that a pilot project always has expectation. Everybody wants one, you know. I just wondered how you're managing those expectations and what the offer is, whether there is ability to for like crisis to sort of come to the agreement.
Okay, so we're not as far ahead as two of the other sites. One in Tower Hamlets, they opened 24/7, so their beds and opened the doors in July last year. They had already been over to Trieste as a group and had come back with plans, so they were ahead of everybody else. For them, they now deal with all their crises within their service. They don't. If you have a crisis, you don't go somewhere else. They've reduced their bed use by 45%, and it's still falling. So, I expect that we will do the same. At the moment, we can't deal with all our crises. We're not open 24/7, and we can't be until we've got the new centre open, which will be in February next year. But I expect that we will deal with all our crises, certainly up until 8 to 10 o'clock at night, that kind of time. And then the following morning, if there's a crisis where someone's ended up in A&E, we will go and bring them out.
I think as well, just building on the catchment area point's a really important one. Just we came into this with our eyes open, thinking, although there is the footprint of a primary care network that probably 95% of the time plus most people are registered at their own local GP practice, but we know as soon as we draw a boundary around something, there's always someone that lives just over the boundary line or on the next street. And it's a prime example of that if you look at Blackstock Road, from Newfield Green at one end of it, heading up to just past Gaunt Shops, moving up towards the Norton end. We've got a GP practice at either end. The one heading towards Norton is in a different primary care network, yet it's on a frequent bus route. You could access Newfield Green within 5 to 10 minutes. So what we've done in terms of our design is we've anticipated this. We do not want you turning up to Newfield Green and the first question you get asked is, what GP practice are you registered at? No, sorry, you can't come in. So we've made sure that through what's currently being called a crisis cafe, it won't be called that when we launch. It's just how we distinguish it. So that's for individuals to self-refer, to turn up to if they were feeling that they were struggling. The VCSE offers and similar like that, they're universal. So if someone rocks up, we will see them. If someone needs the support of more of community mental health or more specialist teams, if they're at one of those GP practices and the teams on site, will help them to get there quickly. If it's from another practice, we build the bridge so that we help that person to get to the service and the corresponding team. Just we've got the best chance of knowing how to navigate our own mental health system as well. So in those scenarios, we've tried to forecast it as much as possible to account for and to mitigate against having really hard lined catchment areas.
I think the other comment I would make is it's difficult to cross the estate itself, isn't it, Liz, as well? It's all right getting from top to bottom.
Thank you. Councillor Lee, did you have a question?
You've touched on a lot of the things I was going to say, but I guess some of the fundamentals you mentioned are the trust relationships, community, co-production, all those things are fundamental to producing a really good service, particularly people with serious mental health problems who often go into a vicious cycle of stress, deterioration in mental health, crises, end up in hospital maybe. So maybe you'll that will be cut short and you will intervene in that circle somewhere and prevent that from happening, as well as other problems that come along that maybe would never turn into a crisis for that individual. So I guess the other one was, and you mentioned it about, what do you demonstrate to the politicians to show this is working and it's going to save them money, because that's what they're interested in. We talk about in this place sometimes it's how we're going to stretch our budgets, and you can say there'll be a reduction in people going to A&E, because there will be if they've got access to something 24/7 eventually. I guess the question is, when these get rolled out, hopefully they will get rolled out across the country, how will they, you've got a lot of enthusiasm, you're a pilot, you're demonstrating something, you've got that drive there. How can that be translated to other services that will want to replicate you but won't have the, that get up and go, that we're the first, we're based on a lot of research. How can you lend your experience to those other teams eventually?
Okay, so answering the first question as I understood it, the very first patient that I was asked to see by a GP was someone who'd been lying in bed for 3 months, diagnosed with schizophrenia, and the GP said he'd got catatonic schizophrenia and that he hadn't been drinking, he hadn't been eating, and his mum was upstairs in his bedroom giving him water. So I went round initially with one of the nurses, and then with one of the senior lived experience practitioners, and we were round there 2-3 times a week to begin with, and eventually we managed to. He was drinking, he was eating, and we managed to get him out of bed, and we eventually got him downstairs. And then I couldn't go on one particular morning, so the person with lived experience went round, who'd also got a diagnosis of schizophrenia, and persuaded him to go for a walk. So off they went for a walk round Bramall Lane and all that kind of, yeah. And he's got to the point where he's sort of saying, do you think maybe you could not come so often? So he said, don't come till next year. Now, it's the family are over the moon. They spent 9 years of trying to get help for this young man who, when I was given the story, I was thinking, why did someone not go and see him at home? I mean, but they wouldn't. And they'd say, well, he's not engaging. And you just think, this is insane. So that's somebody who would have been admitted in that cycle. And he'd been admitted before, and he'd been discharged as soon as they could get him out. And that was when he went to bed. And you sort of think, this we have to stop. Mm. So that was the first one. The second one, the problem that you're identifying, which I think is absolutely right, is what the World Health Organization called voltage drop. As you scale up, the further you get away from it, the less you've got the model that you thought you'd got. And that's now to my mind, we have to make this a national movement. Yeah. So every site that's got money, we meet with them regularly. We're getting them to visit each other, and we are forming a sort of national network. And most of the sites are incredibly pleased to go and tell people what they've done, and to invite people to come and see what they've done. But I agree with you, it's the big danger, is that as time goes on, you'll end up, instead of having a neighbourhood mental health centre, that you'll end up with a mini psychiatric hospital in the middle of Gleedless, which nobody wants.
And I think building on some of that as well is, I think some of the NHS England national colleagues, they're developing a suite of support documentation for other areas to apply some of the learning. That will be informed as well by local and national evaluations. And I think it's trying to find that sweet spot of giving enough instruction and direction, yet local determination is really important, especially around geography. So, for example, what we do in Leeds and Healy wouldn't necessarily be a lift and shift to Grenoside and Stocksbridge. The principles would all be the same, the approaches, the culture of the teams, but how we sort of do some of the additional wiring or configuring, it needs that local determination. We see that quite a lot in those sites, that if you compare, you know, urban versus rural populations, so what's been done in Sioux London sites compared to Whitehaven, their population covers a huge geographic area where beyond Whitehaven itself, they've got villages, little hamlets or similar that way. So again, the principles bind everyone, the approach, the culture does, but there needs to be some of that local determination to account for local needs and geography as well there.
So the evaluation that we've got Ipsos Mori and Centre for Mental Health and UCL to do, that the brief is basically, we're asking each of these sites to metaphorically bake a cake, and we're asking the evaluators to find out what's the essential ingredients to make that a really good cake from their community's point of view, yeah? And what are the contextual factors which either make it more likely or less likely to be a really good cake? And you've got to face facts. The great thing about the NHS is they've always said, we don't want variation. Actually, we want variation with this. We want this to be what the community wants. So Whitehaven is quite different to Sheffield. Driving from one end of Whitehaven to the other takes 2 hours. For us, it takes 15 minutes. Yeah, I mean, unless you're in the middle of rush hour, then it might take quite a lot longer. But Whitehaven is fronted by a very powerful voluntary sector, and they've brought the NHS in, which is, that was how I was working with the homeless population. We were brought into the Archer project, into Sheffield Working Women's Opportunities Programme, into Ben Centre. So that's how they're doing it, is that most of their investment is in a voluntary sector that is all over Whitehaven. And the NHS and are happily partners in it. But the lead is the voluntary sector. Here, the lead is the NHS with a very strong voluntary sector. And in Tower Hamlets, is predominantly NHS. So they are all different, but they're what their communities are saying, this is what we want. So, and I think the voltage drop problem will be less if the communities have a strong say. So we've got to watch that.
Thank you. Councillor Martin, do you have one final question? If you could be as quick as possible.
It's really quick. Well, it's now sort of two, but very quick. I mean, there's one little thing. Just that metaphor about the cake, obviously baking a good cake requires a really great chef as well, and that's part of the problem as well. But anyway, I just thought it'd be really, I would love, hopefully colleagues would agree, it'd be great to come on a visit once you've got your feet under the table in the new premises. Is that February 26th? Yeah. So at some point after that. Yeah, if the committee thinks it's a good idea.
Microphone on, sorry.
Sorry. Yes, the Health and Social Care Select Committee went down to Tower Hamlets, and it was a bit of a jamboree, and everybody had lots of fun and so on. So we would be delighted if any or all of you wish to come.
Thank you. I don't have any questions because my questions have been asked already, but it's really great to hear about it. And I think as a committee, we'd love to come and see it next year. That'd be brilliant. And as and when appropriate, it'd be great for you to come back and bring a further update about some of the outcomes. We'd really like to hear more about this. So thank you very much. If anyone's got any more comments on that, I'll move to Tim.
I've just got a plea really, which is, and I've made this to Kate Joseph as well, and will to everybody that I talk to. Can we try and get everything going neighbourhood as far as possible? It's been remarkable. I went out with a social worker who's employed by the council, Yesterday, we went to see another young man who's diagnosed with schizophrenia, and we had a great session with him and his family, and the social worker was looking at, you know, how to help get a different property for him and all this kind of stuff. And at the end of it, I mean, she said, "Can I come and join?" And you sort of think it makes a huge amount of sense that we all try and pool resources and move into a neighbourhood way of delivering services. You know, if you're in the middle of your community can way more easily take advantage. And, you know, like I say, mental health or psychiatry is a small part of people's lives. Even someone with schizophrenia, it's not the big, you know, alongside it is work, is, you know, it's social life, is family, is, you know. So the more that we can all deliver neighbourhood-based social and health care, the better, I think.
Thank you. I'm going to let Councillor Belbin come in on this point.
Thank you. Just to respond to that, I think it's a really strong piece of feedback that's come from the work we've done around our community strategy, which you may be aware of as well. So that's a piece of work that we've been doing, again, co-produced with the sector over the last year, and certainly when we've been out and tested that with communities, what we hear back an awful lot of the time is, we want to see you here, we want the council to be visible and out there in our communities, and it's certainly something we are looking towards doing more effectively. I cannot promise that suddenly every, you know, service will be delivered on that kind of neighbourhood basis, but certainly it's something we're looking to do more effectively, is to work on that kind of neighbourhood basis. I think some really interesting discussions down the line, actually, around, you talk about 12 neighbourhoods, you know, we can talk about 147 neighbourhoods and some of the work that's been done, you know, what a neighbourhood is. There's
I
all
agree.
sorts of
We think there's probably at least 4
there.
neighbourhoods in our patch.
Yeah.
So the idea that it's a neighbourhood is probably a misnomer.
Yeah, but I think it does lead us to, into some really interesting conversations, and it's very much about how we work with communities to create communities that are more resilient in lots and lots of ways around mental health and all other ways as well. So very happy to continue that conversation.
Thank you. I'd echo what Councillor Bellenby says, and this committee is made up of members from Education, Children and Families Committee and our Adult Health and Social Care Committee. And just thinking of an example from adults, in the last few years our social care has moved to a neighbourhood model, and there's been huge benefits to our communities in doing that. And so you like Francis, we can't promise to do that for everything, but I think it's something that is feeding into a lot of the work that's going on at the moment in those areas. So thank you. So I'll move to our recommendation, if that's okay. So this Health Scrutiny Subcommittee is requested to note and discuss the content of the Healing Legalist 24/7 Mental Health Project report, which I think we have done. So are we all in agreement with that? Brilliant. Thank you so much for your time today, and I appreciate you coming. Thank you. Brilliant. So we'll move on to the next item, which is item 9, which is an update on Harold Street surgery. So this is a written update from Abigail Tebbs from the South Yorkshire Integrated Care Board about the future of Harold Street Medical Centre in Walkley. So I think this came to our committee last year when we heard they were considering the future of services at this surgery, and the report today indicates that following sort of patient engagement and health needs assessment in the area, that its services are still needed. And so it's the ICB to procure a long-term contractor to continue to provide services from Harold Street. So the surgery is in my ward, so I understand a lot of the patients expressed a wish for it to remain open. So I was really pleased to hear this update and that this is the case. Abigail wasn't able to come today and provide this written update. So before we move to the recommendation, I just wanted to ask if there were any comments or questions of the ICB that we would like to send back to them. And just to make a point as well, that in the report itself it refers to an Appendix 1, and that appendix wasn't included, but that was the appendix we received the last time this came to committee, and that reference should have been taken out of the report. So we've had that already, and if anyone wants that recirculating, we can do that after the meeting. Thank you. Ruth, did you have a question?
A comment really, Chair. I find this heartwarming, and we've sat here and, you know, many of us before we were elected as well were you know, racking our heads in despair over closures of things, and that everything just seemed inevitable. And I know Councillor Aris, when he's been chairing things in the past, will have had to, you know, had to see those things come through the committee, and yet another closure, and feeling powerless to do anything, despite the closest scrutiny of processes and consultations. And here, I think we can see that people have been listened to, the engagement has been thorough, they took extra time over it, they've brought thorough reports to this subcommittee, and it just warms my heart to see the rationale for keeping this open, that patients' safety and ability to access appointments would be compromised by closing it, and therefore we will keep it open. I think that's a triumph, and I think we should convey our strong feelings about that to Abigail Tebbs and the rest of the team who've undertaken this.
Thank you. Councillor Mallinson?
Just fully support what Councillor Milsom just said. Fantastic. Yeah.
That's great. I'm sure we can convey that to the ICB. Shall I move on to the recommendation? So the recommendation is that the subcommittee is requested to note the process followed and the decision by South Yorkshire ICB to secure future services for the registered population of Harold Street Medical Centre, taking into account the results of the patient engagement undertaken by the ICB. Okay, agreed, brilliant. And so then we move on to item 10, which I'll let Alice introduce. But I also realised, Alice, at the beginning, I didn't let you introduce yourself, so I apologise for that.
Right, Chair, thank you. Apart from possibly, I guess, most people probably know who I am. Policy and Improvement Officer supporting this committee at the moment. Work programme. Main thing is to, so on page 1, 2, 3 of your actual papers, there was a council resolution about protecting fair, it was part of the protecting fair access to IVF treatment. And it was agreed to send a copy of this resolution to South Yorkshire ICB, requesting that it takes urgent action to reduce the gynecology waiting list. So this was a resolution from full council. And that resolution was asking the Health Subcommittee to consider inviting the ICB to a future meeting to report on progress. So there is a recommendation in here for your response. And that is whether you agree. I mean, my advice is that you have to consider if you want to scrutinise gynecology services, and if so, to add to the committee work programme if you agree to that. So really that's one of the asks of this paper is amendments to the work programme. So as a committee, whether you specifically want to acknowledge that and add it to the work programme. Apart from that, there are a couple of amended items which well, are listed under the amended section, but if you look at the work programme, there are 2 items around primary care update and an update on implementation of continence review, neither of which have got a date as yet. I think it'd be useful to know for you to perhaps consider if they're important for you this municipal year, as there is only the one remaining, I think there's one remaining meeting. There are 2. There's January and March, sorry. I'm confusing myself with the joint health as well. But the primary care update one, I'm a little bit over to you as to the committee to just sort of qualify, if you can, what you think is possibly the scope of that.
Okay, should we take those items in turn? So the gynecology motions come from full council. Would the committee like that to be added to our work programme? Yep. Yep, so we can add that, perfect. And then just moving on to the 2 outstanding items that I think they were scheduled for today, but then obviously we had to cancel last month's meeting. So the primary care update. So it'd be just good to hear from members if anyone's got any comments on the scope of that and what they'd like to hear from primary care. Helen?
I think there's, I mean, the developing neighbourhood model and the neighbourhood pubs that we know have been announced in the 10-year plan. And I think given the conversation that we've just had, there are lots of people working at that neighbourhood level, but it would be really helpful to understand from a primary care perspective what that looks like and what the plan is to do that in an integrated way.
Okay. Any other comments? Councillor Milson?
Yeah, I think what we've heard previously was sort of along the lines of how a bit of a roundup of access, appointments, how patients are finding access to appointments. And I think Healthwatch helpfully provided some information. I can't remember when it was, well over a year ago, I think, when we asked for an update on that would include the status quo on patients accessing appointments. And we did ask questions then about the different systems by which patients were booking appointments and how haphazard that was across the PCNs and different practices. Might be good maybe just to include a bit of an update on those things in scope. Don't know if Healthwatch has done any more work on that, or if a report could be pulled together from patient feedback that you've had. Yeah.
It is a recurring theme. The insights consistently show that that's an issue for people who are contacting Healthwatch or that we're doing engagement work with. So we can certainly bring the insights into that discussion as well.
I wonder as well, Chair, whether with the expanding population in the city centre, whether I think the largest population expansion has probably happened since we had the last primary care update. I don't know, but maybe if we could ask for something specific around capacity in the city centre.
Yeah, that all sounds good. Is that okay with everyone? Brilliant. And so then the next item that Alice highlighted was about the update on the implementation of the continence review and whether we want to continue to pursue this. And my feeling is that we would like to hear an update on this, if possible. The continence review. Yeah, I think so. Brilliant. Is there anything else anyone would like to raise on the work programme before we move on?
Just to note that on the forward items, there's a date for a work programme workshop that says May 25. I'm not clear. Is that meant to be May 26 or is that something that's happened?
If I can, Chair. I think that's just a typo, yes.
Okay.
Me cut and pasting.
Just need to make sure it's in the calendar.
But I will double check. I suppose I could turn it back to you and say maybe it isn't a typo, but therefore is that something that would be helpful for the committee?
I think that would be helpful. That's something we discussed.
Even if it is a typo, we turn it into a future.
Yeah, that would be great. The other thing that is in the minutes of the last meeting, we talked, when we heard from the long COVID clinic about that, we talked about having them to come back for an update in about a year as well. So it'd be good to add that into the work programme so that gets picked up in May when we're work planning. Brilliant. Councillor Mallinson?
I'm just looking for it now, but there was going to be an update in January about from the ICB, and I'm not exactly sure which trust, if any, about equalities and how they address equalities issues. Is it on there? Sorry, I just was frantically looking for it and I couldn't see it.
It's not actually down for January's meeting. I think, Alice, have you started to ask questions of the ICB about what that might look like?
I have.
The trust.
Sorry, Chair. Yes, I have. I'm also being hesitant because my screen's gone blurry. Yeah, I have a long list of catching up, and it's helpful for me to find from you what are your priorities, and the fact that yes, things have been shifted on by meat because of the cancellation of the last one. So if it's on there, it's not been forgotten. Just pursuing when's the best time for it to come. I think there are some, I will say I think the ICB are being as helpful as they can, but obviously they're in quite challenging circumstances now. So
Sorry, Chair. I was just wondering if there is, I mean, if there's not enough to add it to a specific meeting, whether we could have a sort of a briefing update at some point.
About what, sorry, which item?
Sorry?
Which item?
I'm talking about the update on the ICB.
Oh yeah, I mean in terms of the funding situation as opposed to we could ask for a briefing for the committee.
You know, I mean, if it, you know, because I think it could take a while until they know where they are with it. But we haven't had an update for a while. That's all I'm saying. Really.
At the moment, the consultation's underway, so I suppose towards the end of that would be appropriate point. So yeah, we can ask for that. Sorry. The recommendation for the work programme is the subcommittee are asked to that the work programme, the committee's work programme as set out in Appendix 1 be agreed, including the additions and amendments identified in paragraph 4 of the report and any agreed by members at the meeting, and that the referrals from the council and committees, petitions and resolutions detailed in section 2 of the report be noted and the proposed responses set out to be agreed.
Yes, Joe, if you want me to just summarize, I've got yes to gynecology. I've got some good scope from you for primary care update, contents review, yes, an ICB update, probably most suitable as a briefing, work programme workshop, and adding in the sort of coming back around the COVID for May. I hope that sums it up correctly.
Thank you. So all in agreement with that? Great. So that brings us to the end of our meeting. So the next meeting of the subcommittee is on Thursday, the 29th of January at 10 a.m.